Hello and welcome to my channel. This is a case of a patient who had a long-standing retinal detachment, which on ultrasound was evidently funnel-shaped. In these cases, I do employ an encircling band, or cerclage as we call it. And as you see here, there is an attached posterior hyaloid, most likely or at least partly attached, as well as a ring of subretinal PVR, which is usually more common in these long-standing cases. And it's one way to differentiate a case with a horseshoe tear, which is more acute and more likely to have a retinal PVR, and a case of small holes with usually at least partly attached posterior hyaloid. You do find a lot of subretinal PVRs in this latter case. And here I've made a small retinotomy in order to remove at least part of that ring of subretinal PVR and then aspirate that very thick viscous fluid. And as you saw there, that subretinal ring did break, and it allows for the retina to open up. But as you see, the retina is very shortened, it does not redetach. And as I mentioned here, there's a surprisingly little amount of epiretinal PVR, which you would expect at least some degree of. And so at this case, I've actually stained this several times because I was convinced that should be at least some thick ILM over the macula, but here there barely was any ILM, and that fold over the macula is just from chronicity and from most likely a lot of edema. So I do manage to peel off that ILM eventually, just to reduce that rate, that increased rate of secondary macular edema later on. This is a case that will need retinectomy, as you'll see later on. So I try to stay in additional time, do some more peeling under perfluorocarbon, but not much to peel here. It's very friable ILM. Also, I've already inspected the periphery. You see those folds caused by that subretinal PVR ring, so there's nothing to peel there as well. So I decided to do a 360 retinectomy as anteriorly as I could and remove the remnants of that subretinal PVR, which I couldn't remove earlier. Diathermize any bleeding, being as careful as possible not to cut any of the choroid. And that which you saw there at the 10 o'clock location is most likely the causative break. And someone begs to ask the question, uh, are these cases operable? And the answer is, it depends how long they've stood and the status of the macula. And obviously the status of macula you can't know until you've gone into the eye, but if the patient has had vision less than a year back, meaning the detachment is less than a year old, and is willing to undergo surgery, then I do offer them this possibility. At least they will get some central vision, although very poor vision. So laser thorough laser around the retinectomy edges, tighten up that encircling band under air, and fill the eye with 5,000 Scentstoke silicone oil for permanent use. Thank you so much for watching.